A lot of the information that I'm going to give today really comes from a lot of my experience working with medically ill kids in the hospital, and I work with them while they're hospitalized and their families, helping them coping with the stress of being hospitalized and how to kind of prevent maybe ongoing stress once they're discharged and go home. And then working in the outpatient setting with kids who have anxiety and other sorts of disorders. And as we were thinking about this, I'm just pulling all this, experiences together and seeing how they might or might not apply to the specific population of kids with the 22q11.2 deletion syndrome. Just briefly, I'm not going to spend a lot of time because we know, both Elliot and Kathy went over some of this, that it's why, when we think about anxiety, that there is a high rate, 40 to 60% of the kids. If you look at the general population, just to give you a sense of what the difference is, there's a point prevalence at any given point. 6.5% of the kids have anxiety, and over a lifetime, 25% of the kids will experience some anxiety symptoms. It's higher in the medically ill kids, anxiety symptoms overall, and the sense is a lot of it is from the stressors of coping with whatever is going on medically, but there's a whole large degree of variability depending on what the illness is and whether it's predictable or not predictable. And, again, what are the possible causes of some of these increases? Some of it is genetic, that there's a lot of research on some underlying genetic factors that can make you more vulnerable to anxiety, life stressors, and some behavioral modeling that can kind of come in, which, in terms, and I'll talk a little bit more about the behavioral modeling in a little bit. So again, they also, all of this has been covered, but just a quick recap, it can impact a lot of different areas from brain development, chronic anxiety with, high levels of cortisol, as Elliot had mentioned, with immune suppression, social difficulties, a lot of academic problems. It really has a vast impact. But, what often we don't talk about, or we talk about it, but we don't have a great sense of, like, how does this impact parents of the kids who deal with this on a day-to-day basis? And the sense is that it can cause anxiety for the parents, what's going to happen? Am I going to be able to find, support at school? Am I going to be able to find doctors who understand this? Am I going to be able to, help them make it through? Peer groups, all those sorts of questions can make anxiety just be there, even if it wasn't there before. Some of us are more anxious at baseline than others, and it can worsen that. And sometimes it can also then impact parent behavior and how we interact with our kids and how we kind of perceive whether they're strengths or not. And we might perceive the kids as more vulnerable. There's a natural wish to protect. There is despair or sometimes even denial, kind of feeling like, they really don't have problems, they can do great. And that has its own sets of kind of fallback from that. So just briefly kind of, there was one study, I haven't kind of given too many details, but medically ill kids, they were divided into two groups. The parents were instructed, they were going to get some very simple math tasks. These were all teenagers. They were going to add 1 + 1 or 2 + 2, like simple math tasks. And the parents, there were two groups. One group was asked for the parents to say, gee, make sure you don't make a mistake, or look very anxious and start wringing their hands, or they were instructed to look anxious. And there was a separate group that was said, look confident and say, oh, don't worry, it's going to be a simple task. And then they went in and looked at, anxiety before and after, and saw how did they do on the test. And it really, what they saw is that just on the anxiety paradigm where the parents were acting anxious, that's where they found that the kids didn't do well on even very simple tasks that they would have been able to do pretty okay otherwise, kind of correlating from how they were doing in schools. Something else that they found interesting is, we always talk about mothers and, mother being responsible. But something interesting that they found is that the father being more anxious had more impact than the mother being anxious. So depending on who parents, it also, I don't think it has been replicated yet, but at least that there's a role for both parents that play into it. And then there's also a sense that medically ill kids in a similar way learn to expect danger from their experiences, and that's how it could be kind of translated into how we might see this in medically ill kids. And so, medically ill kids, this paradigm kind of gets shifted into what we know a lot in psychiatry, which historically has been called vulnerable child syndrome, and there are other names for it. But basically what it is that, once there's a child who's had some kind of a medical illness or some adversity, there might be a sense on the parent side, which is very understandable and natural, that the child needs to be protected a little more. You need to watch out and make sure they don't get hurt or have negative experiences. And this can sometimes cause the parents to become more protective than they would have otherwise, or view the kid as somehow not having the strengths that they possibly could have. So is it common? And actually there's some study that shows it is pretty common in certain groups of population, either firstborn with medical illnesses or kids who have congenital anomalies, other kinds of handicaps, especially if their parents have known about it and are kind of expecting it to happen because it's been diagnosed before the child is born. So these are all things that can put you at higher risk for becoming more protective of the child. And although the precise incidence we don't know because it's really hard to kind of get a good sense of it, there are a small number of studies, and it puts it at roughly around 10% of the medically ill population. So what are some symptoms that you see in the child when we would kind of think about vulnerable child syndrome? Is that either difficulty with separating, what Kathy mentioned a little bit about separation anxiety, which we see a lot. Also some sleep disturbances or difficulty sleeping on their own, acting at a regressed or younger level to where they are or what their abilities are, some somatic complaints, other behavior problems and school issues. And there's actually a scale, and I won't spend too much time, but there's a scale that's been validated for the preschool kids in terms of assessing for vulnerable child syndrome. And it just kind of goes through 16 questions, and you have to rate it as from a range of like not at all to very likely, and that gives you a sense of how likely it is that that's part of what's going on for the child. And the reason I'm kind of talking to you about this, because there's also a lot of data that parents are doing this because it's natural. You have a kid who's gone through so many adversities, you want to protect them, and that if we educate the parents and let them know about the syndrome, that there's a lot we could do to kind of reduce the incidence, and that it really helps to reduce the incidence of vulnerable child syndrome. And so then, just to kind of complicate things more, part of it is, since we're talking about this give and take between the child having problems, and then that's what makes parents be more protective, is that there's a study, and this is again just generalized anxiety, not in medically ill kids, but anxiety disorders, there are two forms. It's understood that a dopamine receptor might be making people more vulnerable to anxiety. There are two forms of it. One is, let's just call it A1 and A2. The sense is that if you have the A1 allele, you're much more likely to become anxious than if you have the A2 allele. And then there's a gene environment talking back and forth, and the environment impacts what genetic material we have. And so what they did is took kids and they observed kind of child-parent play, looked at their anxiety symptoms before, and kind of rated where they were on the anxiety scale. And they looked at kids for how many negative affects they had during the play, and they looked at parents to code how intrusive parents were during the play and how many positive statements they made about what was going on in the play. So what they found is that in the kids who had the A1 allele, there was the kids didn't have as many or had more negative affect during the whole play, and the parents tended to be more intrusive and made fewer positive statements. But what they found, interestingly enough, is that when they looked at anxiety scales on these kids, if you had the A1 allele, and if your parent was more intrusive and less positive, you had less anxiety. And so that there was this, kind of trying to understand if this is something that a genetic vulnerability can elicit parent reactions that in some way could be protective in terms of forming clinical symptoms. And so this is a big question in terms of, it's not just one thing, it's a give and take, and are there genetic determinants that, cause parents to respond in certain ways that could actually be protective in terms of anxiety symptoms. And the other interesting thing, it didn't matter, they also scaled anxiety in parents, and it didn't matter how anxious they were, but what they did. So, you could be anxious and still learn a way of behaviorally approaching the child, and it still made a big difference. So, again, this kind of just goes to, there's a reciprocal relation. There's a lot of studies that show, it says mothers, but parents' behavior impacts children, but children also elicit certain kinds of parental behaviors. So it's not any one thing, it's really a dance that both participate in. So, kind of thinking of this, are there things that we could do? Can we do something to then put into place things that can increase the positive, the resilience, or help them have less anxiety symptoms despite all the adversities. And I like to kind of think of when you're treating any patient, one of it is to reduce pathology, but the other is to look at their strengths and really bolster that up and do whatever we can to really maximize that potential. And so these are just a short list from a lot of research on resilience and what kinds of things help kids to bolster that positive coping mechanisms and increase resilience. And a lot of it is we can help with the adults' connection with caring competent adults, problem-solving skills, and self-regulation skills are things that can be taught to kids in very somewhat didactic or manualized way, and there can be some positive impact from that. As I was thinking through this with some of my medically ill patients, I came across studies that are largely done in Australia that looked at really early on markers of high anxiety later on in life, and one of the things that has consistently been shown to predict anxiety symptoms later is a temperamental inhibition or withdrawal, where they're kids who watch from the sidelines. They're very anxious to go and play with the other kids, and they either need a lot of parental support or encouragement. And that these kinds of kids later on go on to develop more anxiety symptoms. So they took these kids, and then what they did is took the parents of these kids and did a 6-week intervention of teaching them some parenting techniques or skills, which were largely based on cognitive behavioral therapy. And basically what the intervention looked like was a group of 6 sets of parents, each session, and it went on for 6 weeks. It was 90 minutes each time. In week 1, they basically did a lot of education about how anxiety develops. What are the neurobiological connections in our brain? What are the behavioral modifications? How does what's going on in the brain and the genes impact how we actually seem to come to the final product of feeling anxious? So there was a lot of education that the parents got about just what it means to be anxious. And then in week 2, they help explain this model and then the overprotection and how that might make somebody more vulnerable to anxiety, and how that really from a neurobiological perspective and a behavioral perspective can continue to perpetuate the anxiety. Because the sense is, I see this all the time with my medically ill kids and their parents, is that it's often the hardest thing is, the sense of helplessness of not being able to intervene and do something for the kid, and the sense is if I had something I could do, that it would help not just their anxiety, but also help them help the kids. And so if they understood why the overprotection was problematic, it was really helpful. And then when week 3 to 5, they went over specific steps of how to intervene with anxiety in the child, very young child. These are all preschool kids, and how to restructure cognitive thoughts in that age group and to develop exposure hierarchies. And these are all components of CBT or cognitive behavioral therapy that's commonly used for a lot of these different anxiety disorders. But essentially what they did is took parents and said, we're going to teach you how to do CBT with your child, and in a modified way at a parent level. And the sense was that if you teach something to a parent that could potentially be helpful, you're not going to find a more dedicated group working with the kids. So, and then at week 6, they talked about, what kinds of things could be roadblocks in the future, what to do if things come up, they can go back for refresher sessions or find their individual treater who can help them. So that's what they did. And then when they looked at it, in 1 year, that was the first study that came up. And then the second study continued to follow those kids for 3 years. And what they found was there were significantly less anxiety symptoms in the group that received the parent intervention versus the control group, where the parents were still meeting in groups, but there was no targeted CBT intervention. It was just supportive, let's talk about what's going on. And it was pretty statistically significant, and it was very interesting to see that after just 6 weeks of that intervention, the effects actually carried out till 3 years. They didn't have a lot of ongoing connection other than yearly assessments of anxiety for the child. And so they found that even after 3 years that they still found decreased rates of anxiety in the group that had received parent intervention. And then, they also saw that the anxiety was lower, but it didn't change the kids' inhibition level or withdrawal. They are still who they are in their temperament, but they didn't convert into frank anxiety or clinical anxiety symptoms. And so, the thought is what they're doing now with the study is actually, right now they're doing a population-wide study of this thing where they're going to just make it available to preschool kids on a population-based level, and they're actually working on putting this into place with recruiting teachers and teaching them this and seeing, so not just the preschool kids, but then as kids get into school, that the teachers can do some of this work and maybe see what the impact is. And then they're now, I think, the studies have been going on for a while, so the population that they started with are now teenagers. And so they're looking at them and kind of starting to collect data to see if they still see benefit. And if they did it would be really phenomenal and amazing. But so that's something to wait and see. So you know, the trial itself is called the Cool Little Kids trial, and it's something that's going on right now in kind of Australia on a population-based level. So some of the questions that, you know, I don't know that I have presented kind of today is, you know, would this apply to medically ill kids? And this is something that I'm kind of starting to think about, starting a group on the hospital medical floors for parents when their kids are actively hospitalized, and see if we see any, if we follow these kids and we see any differences in the anxiety symptoms. And then, you know, what about the 22q and 1.2 population? Is this something that we could think about in this population? Would it make sense? What are the unique characteristics? Would we need to tweak it or not? This treatment is actually now manualized, and so it's available to kind of look at and do in a more manualized form. So those are some of the things that I've been thinking about. So just some final thoughts. You know, how can, is this something that if you wanted to just go home now and kind of do something about it? Just in a short way to think about it is what I talk to parents all the time, is kind of use it as a www, which is like every kid's online and internet. So it's that technique. And basically what it is, you know, kind of watch, wait, and wonder technique. It's not very sophisticated, but there's actually a paper out on, you know, that this technique actually works pretty well. And the sense is, you know, first you want to just kind of act as if you're data gatherers. You're just looking at child's behavior, what kinds of things they approach, what kinds of things they don't approach. Is there anything that helps them approach it? Is there anything that doesn't? So kind of just watch. And then, you know, when you see them kind of hesitant or not approaching things, to wait and see what they do about it. You know, can they come up with some solution to it, or do they completely freeze? And if they do come up with some solution to it, that's often very helpful, because then your role could be to help modify them and make it much more simpler, more applicable, and more streamlined for them to use that. And then the wonder technique is if the child comes to you and brings up, you know, what should I do? I'm confused. Psychiatrists get blamed about this all the time, but the wonder technique is basically like, I wonder what we should do, and see if just the encouragement of saying, I think you might be able to solve this. Let's wonder together in a way that you're wondering with the child and not so much for the child. And that often helps them learn that maybe they can internalize some of the techniques of problem solving just by being modeled by the parents. Some of the other things that are often helpful is kind of increasing your knowledge and the child's knowledge of what does it mean to have this syndrome. And you guys are all here today, so that's great, you're doing that, but there's a lot of data that increasing knowledge about anything really brings down anxiety, and so the more you know, the less anxious you feel. And then if you feel like, you know, you really need help, there are therapists and psychiatrists out there who can help you with that. And so that you know, so there's a whole literature on kind of the psychiatric side of how anxiety can be helped. And then kind of finally, and I'm going to end a little early, but it's kind of what all of these papers talk, and I really like the Australian studies that I mentioned. The first author of that study, Dr. Jupri, who's a PhD psychologist really interested in anxiety, outlines, you know, the bottom line is that what he tries to do is teach kids that, you know, not that the world is a scary place, but that the world is a place with scary things. And that's a big distinction, that it really helps the kids to feel that there could be positive things, you know, with the adversities, that it's not all negative. So that's pretty much it. These are all some of the references that I used, and I would like to thank, you know, the Hubble team for having me on, and I'm excited about joining and all you guys to be here today. Thank you.